Thank you. Jack Tay gives his regards. He could not come from Singapore, but I will do my best to deliver an outstanding talk that he prepared for the group. Start with a very famous quote from Lord Whitmore regarding prostate cancer. If treatment is necessary, is it possible? If possible, is it necessary? These are some of the largest studies and trials to date looking at outcomes. Does everyone need treatment? Lori Klotz is looking at active surveillance, including some low-risk, intermediate, 4% metastasis, 1% cancer-specific. And then when you compare that to the Hopkins, very select group of all low-risk men, 1% chance of metastasis. And then you go to the SPCG4 with 20-year outcome, RP versus watchful waiting. RP is better, especially intermediate risk. You have the PIVOT trial, low risk, 10-year outcome, very similar CSM and OM, and then PROTECT, similar. RP and RT have half the metastatic rate for their intermediate risk. We've been addressing this question through contemporary consensus panels, through the focal therapy in regards to patient selection. You can see on the left the goal, disease factors, disease groups, size, et cetera. Back in 2010, the goal was to eradicate all cancer. We didn't tolerate any residual disease. And then in 2019, we are focused on completely degrading clinically significant cancer and are comfortable with leaving some degree of Gleason 6 behind for observation. So in terms of focal therapy, success is defined by accurate staging and grading, accurate three-dimensional intraprostatic positional determination, the ability to ablate the cancer adequately with a low rate of complications, and the ability to preserve GU function and to detect and salvage recurrences if and when they do occur. So trying to define what our target is when we talk about how many biopsies are they necessary, how many prostate cancers are unifocal. This is a very thorough summary of what's available in the literature. You could see in terms of unifocal, it ranges from a low of around 12% up to a 66%, but in general, 20% are unifocal, 80% are multifocal. And then we know from Hash Ahmed's paper regarding the index lesion and the origin of prostate cancer that most of the time grade and stage is determined by the index lesion, and most of the tumor volume is contributed by the index lesion, and the majority of the smaller satellite tumors are low grade and small, and that genetic studies do in fact suggest a monoclonal origin of lethal prostate cancer. So this is how we defined, how many biopsies are needed. It depends on what you're trying to do, what you're trying to detect, et cetera. Can imaging reliably identify index lesions? Bacco in 2015 looked at this, and their group said yes, 95% of the index lesions were identified, and Lay et al. In 2015 broke this down a little bit further, and their answer is more nuanced. So if you look at the left there, if you have a larger tumor diameter over 3 cc's or centimeters, then the answer is yes, that MRI and imaging can detect it, but as they get smaller, less than 0.5 cc's, the answer is no. And that's also dependent on Gleason score. For those patients that have higher Gleason score lesions, the ability of imaging to detect those increases. Targeted biopsy to detect clinically significant disease in the index lesion. You can see there that based on grade, Gleason 6, 7, 8s, and 9s, the concordance rate with radical prostatectomy and biopsy. For Gleason 3 plus 4, it's quite good at 85% with targeted biopsy, that is. And then when you get to Gleason 8 and 9, I think they don't have sufficient numbers really to reach significance. This is the NIH data, Siddiqui et al., Peter Pinto's work We're all familiar with MRI fusion biopsy has been shown to be superior to standard biopsy. And I think this goes without saying that we all accept this for what it's worth, but we also have to understand that 45% of clinically significant cancers were missed by standard trust biopsy, and I think this is a number that's worth remembering. This is Mark Emerson's precision trial. Again, looking at the PIRADS score, if you have a PIRADS 5, most likely 83% chance that you're going to find a clinically significant cancer when that's biopsied. PIRADS 4, 60%, and then when it's PIRADS 3, it goes down to 12% for clinically significant cancer. And they found that overall, fusion performed better than trust biopsy. But MRI has significant false positives. We have to recognize this. And in this study by Rourke et al., it was determined that 60% of false positives were found in PIRADS 5 lesions, and 40% of PIRADS 4 were caused by inflammation. We looked at our Duke series and found that there was sometimes discord information by what we thought we would get with the PIRADS score versus what we got pathologically. And we feel that was presented at this meeting that sometimes the size criteria is a factor. So when you're making a lesion a higher PIRADS score because of a size criteria, you can introduce false positives as well. And this is an example of a false positive MRI. You can see that outlined by the arrows, and then you have that compared to the whole mount pathology. This is Law et al.'s work. So we all have these targeting systems now. It doesn't really matter what the platform is. We could target lesions based on MRI fusion, and then we have the question of, well, how many random biopsies do we do, if any? I mean, perhaps the Europeans feel that we shouldn't do any random biopsies, but in the US, we tend to do some. Traditionally, it's 12, and then you have to ask yourself, is that warranted, and what's the yield of adding the 12-core systematic biopsy? I think the issue for the patient is sometimes they feel like a pincushion. I mean, you have these grids, they have holes drilled usually every 5 millimeters, so you can stick as many needles as you want. We have 3D mapping biopsies. Sure, it provides really great pathological assessment that probably is as good, maybe if not better than surgical pathology. But then really what's the trade-off between too many biopsies versus not enough biopsies? And this is a unresolved question. I think that everyone in the field wants to go forward with doing no biopsies. We've heard that mentioned at the meeting, but there should be some balance between some biopsies and no biopsies, at least in my opinion. This is looking at oncological outcomes with a mandatory rebiopsy. This is a summary of 13 cohort studies with pre-focal therapy MRI and mandatory rebiopsy at 6 to 12 months. You can see on the right you have what's defined as infield recurrence, which would be an incomplete ablation, and then under that is the out-of-field recurrence, basically representing either a missed cancer at the initial time of staging or a de novo cancer. And you can see by the bar graph about 20% chance of infield cancer detection with a mandatory rebiopsy for any cancer, and then that goes down to about 10% with clinically significant outfield, probably around 20% as well, but outfield clinically significant disease is much lower at about 10% estimate. The PROMISE study has shed some light on this when looking at paired comparison of MRI truss biopsy to mapping biopsy. And in that study, which is multi-center, international, the negative predictive value of MPMRI was in the region of 76 to 89% for clinically significant prostate cancer. So is concurrent systematic biopsy negative? We're going back to Peter Pinto's data from the NIH. There's always different ways to look at this data, but 5.3% of men who were believed to have no cancer or low-grade cancer were upgraded by systematic biopsy. And then you have to ask yourself a question: is the 5% for your patients significant? It's a small number, but it's 5% nonetheless. Filson et al. Try to answer the question, is concurrent systematic biopsy necessary? They have 1,000 patients in this study. And as you can see in the two middle bar graphs, the middle one representing targeted only, and then on the right, you have the combination. Clearly, there is some differential between the combination and targeted only, and the false negative rate of targeted biopsy was deemed to be 18%. This is a nice study that looks at 500 patients, standard biopsy only, 12-core, fusion biopsy only, and then both in nice colored bar graph. And the finding overall is that 16% of clinically significant prostate cancer is detected by systematic biopsy alone. So that's roughly 15%, and that's the number that we more or less carry around with us. So when you're doing these fusion biopsies, the question is, what do you do with these standard biopsies, saturation, how many is too much? This is a study by Chen et al. Looking at clinically significant prostate cancer. They found it in 55% combining systematic plus fusion. Systematic alone was 19%, target alone was 26%, and these numbers are relatively consistent. When they looked at this, they found that MRI trust volume discrepancy had a 2.8 odds ratio, and a lower PI-RADS score were the significant predictors. When do we not need a systematic biopsy? I think this is an interesting study. It shows that if you have a PI-RADS 5 lesion, systematic biopsy will upgrade it only 3% of the time. So very, very low chance of upgrading by adding a systematic biopsy to a targeted PI-RADS 5 lesion. We've discussed this before, contemporary consensus for patient selection for focal. If you look at this over time, 2010 to the last decade, we were doing mapping biopsy back in 2010. This has progressed now to MPMRI targeted biopsy, some degree of systematic biopsies, but we feel that MRI is integral. So in summary, MRI remains the imaging modality of choice, but histological confirmation is still required with a targeted biopsy. Truss and template biopsies alone may still be relevant for men not eligible for MPMRI for a variety of factors. Systematic biopsies may detect an additional 5 to 18% of clinically significant prostate cancers, especially in scenarios with less certainty. In other words, low PI-RADS, fusion or segmentation errors, and ultimately how many cores are enough. I think this remains an unanswered question, but I wanted to share with you based on a review of the literature. Thank you for your attention.